The last thing I want to go over is the staging and management and the presenting symptoms. The presentation of these cancers is always something to do with bleeding. Now, always is a strong word, and sometimes women will present with just an atypical discharge. A woman with a serous carcinoma can have a serous or watery discharge that's not obviously bloody. But just for basic teaching point, the classic presentation for women with endometrial cancer is postmenopausal bleeding, or if the woman is premenopausal bleeding, some bleeding abnormality. It might be new onset menorrhagia, it might be a long history of irregular menses that is now even more irregular or heavier than normal. And the question is going to be in these women is who to do an endometrial biopsy. The answer is if you're postmenopausal, biopsy everyone. Don't have a discussion about how much someone is bleeding in order to make the decision to biopsy them. The reason to have the how much conversation is so that you can decide whether to evaluate them for anemia, for example. But the issue of whether to biopsy them, a single drop of blood needs to be investigated and needs to find a source. And of all the women who are postmenopausal with bleeding, 25% or more will have a malignancy. There are other causes, polyps, uterine atrophy, or a problem in the fallopian tube or even within the intraperitoneal space. But that all needs to be investigated. The bigger problem as far as who to biopsy are women who are premenopausal. Who do you biopsy there? The safest thing to do is to understand what's their long-term risk for being a type 1 endometrial cancer patient, i.e. if they've had years and years and years of monthly periods and they've had a month or two of irregular spotting, they won't have endometrial cancer. It typically takes years of oligoovulation and relative excess of estrogen and a dearth of progesterone because they're not ovulating. It takes years of that to develop both hyperplasia and then a malignancy. So that should tell you that if someone does have years of having PCOS type symptoms or oligoovulation history, at some point, particularly in their 40s, they should have a biopsy. And the reason I say in the 40s is the rates of type 1 endometrial cancer in premenopausal women as teenagers or in their 20s is quite low. It starts to rise in the mid to late 30s and then rises quite a bit in their 40s. Of all of the premenopausal endometrial cancers, type 1, 90–95% of them arise in those between age 40 and 50. So focusing our biopsies on those patients who've had long-term risk is probably the most prudent thing to do. As far as staging and management, patients with endometrial cancer need to have a hysterectomy. There are exceptions to that, and the exceptions would be premenopausal women with a grade 1 cancer who desire fertility. And this certainly does arise. These are problematic, but we certainly honor those wishes and do heavy consultation with patients as far as what their choices are and make attempts to manage them medically. The reversal of endometrial cancers using medical management is fraught with problems, but it can be successful. And we'll do a separate lecture on that subject. The hysterectomy is the time-honored way to manage these patients, and the methods for hysterectomy can include total abdominal hysterectomy, a total laparoscopic hysterectomy, a laparoscopically assisted vaginal hysterectomy that aren't being done too much anymore, a robotic hysterectomy, which is just another way to do minimally invasive surgery. What's typically not done is total vaginal hysterectomy because there's no intra-abdominal evaluation through this method. Exceptions would be for the extreme elderly who staging information isn't necessarily needed. And definitely not a laparoscopic supracervical hysterectomy, because this leaves the cervix in situ and also requires morcellation of the uterus, both of which are contraindicated in the presence of a malignancy. In addition to the hysterectomy, the other things that need to be done to correctly manage this are washings, which is a way to look for free intraperitoneal malignant cells. And then, depending on one's age, classically we remove both tubes and ovaries, bilateral subpinguophorectomy. That is certainly negotiable in a premenopausal woman with a low-grade cancer. And then, in addition, if a woman has a malignancy, she should have pelvic lymph node dissection done. Depending on the grade and the depth of invasion into the wall of the uterus, a para-aortic node dissection can be done. And furthermore, for some cancers, we include an omentectomy and stage those patients very similar to staging of the ovary. Staging information allows us to figure out what stage they are, stage 1, 2, 3, 4, and that guides our therapy and is prognostic. In a separate lecture, we will discuss details of staging as well as potential post-operative treatment for endometrial cancer, including concepts around radiation and chemotherapy. That's all for now. Thank you very much.